Stanford University.
Thanks for staying for my talk. It's going to be a hard act to follow. Ron Dahlman's talk was great. I really enjoyed that, Ron. I particularly liked the video. And actually, after seeing that, I think everyone wants to hear about how to reverse vascular aging. So
it's a setup for you, John.
It was a setup. It was good. Thanks. And I was going to talk about the concept of vascular age. I'm going to do that. I'm going to talk about that in a minute. But after seeing Ron's video, I really think that I should start maybe with what you can do today to reverse that process that you saw on the video. And the good news is that there are actually a few things that you can do. And I think actually I'll make this part of the interaction two ways. So if you have some questions related to how you can prevent ending up on Ron's operating table, we can talk about that. But the good news is that there's a lot that you can do. The risk factors for that disease, for atherosclerosis, which I'm going to talk about in a moment, are the ones that you know: high blood pressure, high blood sugar, diabetes, high cholesterol, and aging. And then there's some other risk factors, but tobacco is another major risk factor as well, sedentary state. So we have good medications now to treat those risk factors. So if you go onto the American Heart Association website, it will tell you what your levels should be, your blood pressure, your blood sugar, your blood cholesterol, your HDL, your LDL cholesterol, your triglycerides, what amount of exercise you should be getting. It's all on the American Heart Association website. It's got good information, and you should take a look at that. But if you do have an elevation of one or more of those risk factors, you really should see someone who has an interest in vascular disease, in cardiovascular disease, someone who's interested. That could be an internist, it could be a vascular medicine doc, it could be a cardiovascular specialist. But you should see somebody that can help you with that. So for high cholesterol, statins are great drugs. They're very effective in lowering cholesterol and have been shown in many studies now, at least 24 large studies with 5,000 to 10,000 patients or more, to reduce major adverse cardiovascular events, heart attack, stroke, by about 30%. Then there's another class of drugs that are also very good at reducing vascular aging, and these are the ACE inhibitors, the angiotensin converting enzyme inhibitors. They've been used to treat blood pressure, but even in individuals that have a normal blood pressure, if there's any evidence of vascular disease, they should be on an ACE inhibitor because they're also vasoprotective. These are drugs like Vasotec. Again, the American Heart Association goes over these classes of drugs. So it's used to treat blood pressure, high blood pressure, but it's also useful in people that have normal blood pressure but have some evidence of vascular disease. The beta blockers actually are quite good as well. Beta-adrenergic blockers slow down your heart rate, lower your blood pressure, reduce the wear and tear on your vasculature, and are also associated with a reduction in major adverse cardiovascular events. Antiplatelet agents, the most common one is aspirin, but there's others that are more expensive, but perhaps in some cases more effective. Plavix is one of those. In terms of other things you can do that are non-pharmacologic, exercise is far and away the best thing that you can do for yourself. And it actually doesn't take a lot of exercise to have a beneficial effect. John Myers and Vic Froelicher here at Stanford have shown, actually with some very nice epidemiologic studies involving tens of thousands of veterans, that just modest exercise is enough to significantly reduce your risk. They divided the vets that they were studying, tens of thousands of vets, into quintiles of exercise activity. So at one end you had couch potatoes in the first quintile, and in the fifth quintile you had people that were out there, running half marathons, and then you had those in between. The second quintile, the people that just got off the couch and walked, maybe 30 minutes a day, hardly enough to break a sweat, but just a very low level of exercise. Gained about 75% of the maximal benefit of exercise. So you can go out and run half marathons, and you'll get 100% of the maximal benefit. But if you just get off the couch and walk a half an hour every day, you'll get 75% of the benefit. So even modest exercise, daily modest exercise, is very beneficial. The other thing I recommend is a Mediterranean diet, and I recommend that on the basis of a study that was done in Lyon, the Lyon Diet Heart Study, which was actually stopped after enrolling 5,000 patients over a 2-year period. In this study, they compared a Mediterranean diet versus the American Heart Association Step 1 diet, the standard American Heart Association low cholesterol diet. The benefit of the Mediterranean diet was so great, 70% reduction in major adverse cardiovascular events. The Data Monitoring Safety Committee decided to stop the study because it was clearly a better diet. So I try to follow evidence-based medicine in my recommendations to my patients, so that's why I favor a Mediterranean diet over all the other diets you see out there. The other thing I've been interested in is, over the years, is supplements. I've taken an interest in this because of my own research. And there's a lot of talk about different supplements, antioxidants and fish oils and other agents that might be useful to prevent vascular aging. And there's certainly small research studies suggesting this supplement and that supplement. But really the only supplement that I think is beneficial, on the basis of large evidence-based studies, are the omega-3 fatty acids. And even that is somewhat controversial, but I think that the benefit in people that have had a heart attack is strong, and the benefit for diabetics is strong. Good evidence-based medicine, randomized clinical trials show that fish oil is beneficial in those groups, people post-MI, people that are diabetic. The other supplements, I used to recommend vitamin E. I was a cardiologist to recommend vitamin E 15 years ago until the HOPE study. The HOPE study had 20,000 patients enrolled in it. 10,000 got vitamin E, 10,000 did not. They got placebo. Patients were also randomized to ramipril, which is an ACE inhibitor, ramipril or placebo. So the individuals that received ramipril had a 20% reduction. This is the ACE inhibitor I was telling you about earlier. Had a 20% reduction in their cardiovascular events. These are normotensive people that were at risk for having heart disease because they had other risk factors. They had high cholesterol or they had vascular disease. So in the HOPE study, there was a benefit with the ACE inhibitor, ramipril. There was no benefit of vitamin E. 10,000 patients received vitamin E, 10,000 did not. There was no difference in major adverse cardiovascular events. And there's been a number of other studies that have come up with similar findings. So vitamin E, an antioxidant, is really not useful for preventing cardiovascular disease. Now, antioxidants may have other uses, and I can't comment knowledgeably on the other uses. I know in the ophthalmology field, there's some evidence that selenium, vitamin C, and zinc, an antioxidant formulation that's used in the ophthalmology field, might be beneficial in preventing age-related macular degeneration. But in terms of cardiovascular disease, the only supplement that seems to be useful are the omega-3 fatty acids. Now, you don't need to get it from fish oil necessarily. And the other problem with fish oils in the nutraceutical stores is that there's a great range of, there's a heterogeneity in quality. There's a guy by the name of Tom Saldine who did a study of different fish oils in the nutraceutical company stores. And there were some that were quite good in terms of reducing oxidant stress in the blood, lowering your oxidized lipids. There was actually one formulation that made things worse. It was a formulation of fish oil that was oxidized, partially oxidized. A very crude way of telling if your fish oil supplement is any good is to smell it, crack the capsule open or open the bottle, take a whiff, and there might be a slight fishy smell, but if it's a strong fishy smell, it's oxidized and it's no good. I get my fish oil from a company that I checked out. I looked at their mass spectroscopy of their compound, looked for the oxidized lipids. Carlson is the name of it, and they have a very nice fish oil supplement. But you don't need to get your fish oil from fish. They do. You can also get fish oil from from plankton. It turns out that fish actually don't make omega-3 fatty acids. Fish don't make fish oil. Fish oil comes from plankton. So it's plankton make the omega-3 fatty acids. Small fish eat the plankton. Larger fish eat the small fish. That's where fish get their fish oil from plankton. So there's a company called Martech that's growing up huge vats of single-celled organisms, plankton, and isolating the fish oil from the omega-3 fatty acid directly from the plankton. And that product is called Neuromins, Neuromins, and it's you can take that supplement without fear of having something in the food chain, something that the fish have been eating, mercury or some organic compounds that can get concentrated in the food chain. Those supplements, Neuromins, don't have that. You don't have that concern because they're isolating them from these vats of single-celled organisms. So that's a good way to get omega-3 fatty acid. Another way to get omega-3 fatty acid is from flaxseed oil, which is by far in a way holds the land plant record for omega-3 fatty acid. Flaxseed, about 60% omega-3 fatty acid. The next is are nuts, but nuts have maybe 10% omega-3 fatty acids. Question?
I thought I read that humans are really bad at converting ALA into longer chain fatty acids.
Yeah, that's right. We can't do it, and that's why we need to get it some other way. So we get our omega-3 fatty acids from fish or from flaxseed oil, linolenic acid. We can convert that into omega-3s. Yeah.
You have a quick definition of a Mediterranean diet?
So a Mediterranean diet would be a lot of vegetables, fruits and vegetables. It would be a lot of food that contains omega-3s, a modest amount of alcohol, one or two drinks a day is what the American Heart Association says we can get away with. But there is some evidence, actually in diabetics particularly, a modest alcohol consumption is useful. So.
A lot of olive oil.
Olive oil is good. It's not as good though as the omega-3 fatty acids that you get in flaxseed oil. Or the problem with flaxseed oil is it doesn't taste as good as olive oil, and you can't really cook with it. But if you mix it with a little balsamic vinegar, you can put that on your salad. That actually tastes pretty good. Balsamic vinegar and the flaxseed oil, actually, it's a nice combination. Yeah.
Yeah, I wanted to ask my question again about tests that can identify, quantify the degree of atherosclerosis.
Yeah, that's a good question. I have that on the presentation, so I'm going to get to that. That's a good question. Yes, sir.
You talk about diets. Any comments about the vegan Ornish type diets that are vegetarian ones?
Well, the Ornish diet works, but most people can't tolerate it. So I think that's the problem with the Ornish diet. But if you can do a vegan diet, Ornish diet, very low cholesterol diet, low fat diet, then that certainly works. But the problem is that most people can't adhere to it. Yes. Yes, ma'am.
Follow up on the question about ALA. Does flax oil have any DHE or EPA in it?
Sorry?
Does flax oil have any DHA or EPA in it? Any fish oil in it at all?
No, it's not icosapentaenoic acid or docahexanoic acid. It's linolenic acid. And I think the gentleman was making a good point that we're not as good at converting linolenic acid to the arachidonic acid, the docahexanoic acid and icosapentaenoic acid, but we can. And actually, the proof of the pudding, at least, is that when people that take flaxseed oil have they have evidence of lower inflammation, lower circulating levels of adhesion molecules, and so it seems to be useful.
Like 5% or some very, very low.
Yeah, you might be right about that, but it does seem to be useful in the controlled studies that have been done in terms of reducing surrogates of vascular aging, like inflammation. I think I'm going to go on with this talk now, but one more question.
You alluded to fish oil pills going bad afterwards, and you can test them. I have some that.
Well, it's a crude test. I mean, just cut it one open and smell it. If it smells really fishy, it's probably oxidized. So that's a crude way of doing it. But like I said, the fish oil I get is from Carlson. They're pretty good. I don't have any interest in them, but they have pretty good fish oil derived from North Seas cod, and they put, they make good product. Okay, so I'm going to go on with this talk, tell you a little bit about vascular aging, and a little bit about, kind of answer the questions that you were asking, but also tell you a little bit about what our mission is from a research standpoint. We're interested in building new blood vessels. We're interested in restoring vascular health and reversing vascular aging. And I really believe this. One is as old as one's endothelium. This is the lining of the blood vessel. And it's been something I've been studying for the past 25 years. So it's been a constant thread in the research I've been doing is endothelial function, endothelial health. Now, Ron was talking to you about this entity, aortic aneurysm. These are the major causes of death in this country, and they're all vascular causes. This guy looks like he's having a heart attack, and well, he is. He's having damage to his heart here. It's got myocardial infarction, but it's really not a problem with the heart per se. It's a problem with the blood vessels. It's a problem with the arteries that are supplying his blood with supplying his heart with blood. Aortic aneurysm we talked about. Also, kidney disease. A lot of kidney disease is really a vascular disease. So renal vascular disease, the arteries supplying the kidney with blood become diseased. And you get these infarctions in the kidney that damage the kidney, and you get plugging of the small vessels in the kidney. So it can't filter the blood properly. Here's a brain, carotid artery, we saw that earlier. Here's someone that's had a stroke. This is the brain in cross-section, and this hemorrhage that's occurred in the brain is due to damage to the brain because of poor blood supply, but it's a vascular problem. So vascular aging, vascular blood vessel disease is the #1 cause of death and disability in the US, and it's still causing almost 1 million deaths a year. So it's a much bigger problem than anything else, including cancer. So how did this start? How does this disease begin? It begins with with the endothelium. The endothelium is the lining of the blood vessel. It's a diaphanous film of tissue. It's only 1 cell layer thick. It's like Teflon coating of the blood vessel. Ron mentioned the media. The media is the wall of the vessel, and the adventitia is the connective tissue around the vessel that kind of holds things together. And the wall supplies some ability to contract or relax the vessel lumen. And the endothelium regulates the vessel below, the vascular contraction, and it also regulates the growth of the vascular smooth muscle. I'll tell you a little bit about that. Here's a real vessel in cross-section. This is a healthy vessel. Here's the adventitia. This is the media, the vascular smooth muscle that can contract. It supplies strength and some elasticity of the blood vessel. And the endothelium can barely be seen here. It's just 1 cell layer thick. So that's what a vessel looks like. This is the endothelium at a higher power view. We're looking down on the vessel right now by scanning electron microscopy, and you can see the endothelial cells that line this vessel. It's 1 cell layer thick. It's this film of tissue, delicate film, but it exerts tremendous control over the underlying vascular smooth muscle. It releases growth factors that can regulate the growth of the vascular smooth muscle, releases relaxing factors and constricting factors that can cause the vessel to relax or to contract, to change the lumen size. And it's when this endothelium, this Teflon coating, becomes abnormal that things begin to stick. And that's how vascular aging begins, how atherosclerosis begins. This is what it looks like. We're looking down again on the endothelium. And again, this is a high power view, scanning electron microphotography. We're looking down the endothelium. What you're seeing are white blood cells sticking to the endothelium. And this happens to be a rabbit, aorta, but same kind of thing is thought to be going on in humans. These monocytes are adhering to the endothelium. It's lost its Teflon nature after 1 week of a high-fat diet. And the endothelium is now expressing adhesion molecules that are allowing these leukocytes to adhere. And here they are again, higher power view. This is a transmission electron microphotograph just showing this monocyte grasping the endothelium. This one's actually being caught in the act of going in between two endothelial cells. What are they after? Well, they're after LDL cholesterol that's gotten into the blood vessel. If you have had high cholesterol, the cholesterol gets into the blood vessel and it gets trapped in the blood vessel and gets oxidized. Well, the vessel doesn't recognize oxidized lipoprotein as self. It's recognizing it as a foreign antigen. So this is actually inflammation. It's an inflammatory response against what the body perceives as an invader, a foreign antigen, this oxidized LDL cholesterol. Or if you're a diabetic, this could be glucose that's become adherent to proteins, and you have these advanced glycosylation end products forming. You guys have seen how meat browns, if you leave it out, that's called a Maillard reaction when the meat browns. And what's happening there is that there are glycosylation end products being formed in the meat. Well, high glucose meeting the blood vessel wall forms this kind of Maillard reaction. You get these abnormal proteins that are called advanced glycosylation end products, or AGEs. Anyway, the endothelium, in response to this, starts making adhesion molecules that allow the monocytes, the white blood cells, to adhere and to come in. And the monocytes are going after these abnormal products. And what happens next is that these white blood cells become loaded, in this case with lipid, could be the advanced glycosylation end products. And this is a macrophage in the vessel wall that's become loaded with lipid. Because in this case, again, this is a rabbit. The rabbit was fed a high-fat diet for a prolonged period of time. And with this high cholesterol coming into the vessel wall, the monocyte just stayed there and absorbed the cholesterol. And what happens is that if you continue to have high cholesterol, the monocytes keep coming. They get trapped in the vessel wall themselves, and they form these streaks. These are the first visible lesions of atherosclerosis. Now, this is a human vessel. Now, this is a young individual at autopsy. What you're seeing is the bifurcation of the aorta in a young individual, and not the bifurcation, but a branch. And you can see atherosclerotic plaque. These are fatty streaks. That's the first grossly visible lesion. That kind of lesion occurs in our society. That occurs at the age of 20 or so. We start seeing this, and we know this from the Korean War. It was first evidence of this. Pathologists noticed in some of the soldiers that had died that autopsy. Already they had these fatty streaks, and actually some had fairly advanced lesions. Here's a higher power view of the fatty streaks we were just talking about. Now, what happens next is that these macrophage can burst through the endothelium. The endothelium is this glistening layer that's covering the vessel, but the endothelium is getting distended here, and you can actually see a little erosion and some red blood clot, just a small little clot. I've got a higher power view here, and this is what's going on. The endothelium is overlying this area. It's been distended, and the macrophage have burst through, and now platelets start adhering. The platelets in the macrophage begin to make substances, growth factors, platelet-derived growth factor, and other growth factors that cause the vascular smooth muscle cells to start migrating into this area. And so this is how the plaque forms. You start having cells, you have the inflammatory cells come in first, and then you have disruption of the endothelium, and you have ultimately you get these large plaques that we saw earlier in Ron's video. So here's a large plaque that's filled with fatty debris. Now, this can cause symptoms. This can cause chest discomfort with exercise if it's in a coronary artery. It can cause leg pain if you have it in a femoral artery when you're walking because you're not getting enough blood flow. This is hemodynamically significant. It's obstructing blood flow. But what causes a heart attack is when this ruptures. This is the fibrous cap over this lesion. And if this breaks down, this stuff is released into the blood. It's highly thrombogenic. Remember, Ron told you when they have that carotid artery, before they open it up, they have to make sure that the patient's on heparin, this anticoagulant. Because this stuff is procoagulant. It's highly thrombogenic, meaning it will cause a clot to form on contact with the blood. So when this plaque ruptures, that's what causes a heart attack. A little bit of this leaks out into the blood and you get a clot, and that causes the heart attack or the stroke. So that's the process we want to prevent. That's just kind of a summary of what I just said. Okay, now, vascular aging. This is the article that Dan sent around from me, and it was basically a way to calculate your vascular age. Did anyone bother to calculate the vascular age? It's okay, we're going to do it right now. So get out your number 2 pencils and your paper, or your iPad, and so we're going to do this calculation. So this is from one of my favorite medical journals, the Wall Street Journal. And, but it's a good article, and you can take a look at it. It's quite nice. But there are actually a number of ways to calculate your vascular age now. And they take advantage of what's known about risk factors and how rapidly they can, these are associated with vascular aging. If you go to the American Heart Association website, www.heart.org, you can get more information about this particular assessment of risk factors. So they take into account the standard risk factors: gender, age, LDL cholesterol, blood sugar, blood pressure, tobacco, obesity, sedentary state. They don't really take into account family history, but that is an important risk factor. Okay, so now we're going to calculate your vascular age. So step 1 is to calculate your risk points, and you're going to tally up your points from the 6 categories that I'm going to show you next, and you're going to each calculate your own vascular age. Okay, you start here. Take a look. Ages 30 to 75 plus. So you get men have one column, women have a different column. And if you're over 75, you get 15 points if you're a man. If you can't see the numbers, give yourself 20 points. Okay, everyone get that? So that's your first point. If you remember what your total cholesterol is, and I think probably most people here know what their total cholesterol is, you can give yourself points based on that. So the American Heart Association recommends having a total cholesterol under 160. So if your total cholesterol is under 160, you have 0 points. If you're 280 plus, you should be talking to me after the lecture. HDL cholesterol, you want to have, this is the good cholesterol, you want to have a high HDL cholesterol. And notice that if you're over 60 HDL cholesterol, 60 milligrams per deciliter, that's really good. You get to subtract 2 points from your score. Okay? Everyone got that? Okay, now you have to choose A or B. If you are not being treated for hypertension, go to A and look in the columns there in A and add these points to your score. If you're on antihypertensive medications, if you're on an ACE inhibitor or a beta blocker, or angiotensin receptor blocker, you need to go to this column B. Look at the blood pressure values there. This is the systolic blood pressure. Okay, so that's the upper number. And again, the American Heart Association hopes that your systolic blood pressure is less than 120. 120 to 129 is kind of high normal. 120 is ideal or less. If you're a smoker, you have to add 4 points if you're a man, 3 points if you're a woman. If you have diabetes, you have to add 3 points if you're a man, 4 points if you're a woman. Okay, everyone got that? So now we're going to total the points to determine your vascular age, add them all up. And then in the column there, total points, you look for your total points. And then you have your vascular age if you're a man right below that, and vascular age if you're a woman in the last row. Okay? So that kind of gives you a rough idea of what your vascular age is. Now, we'll do mine. So my age is 57, I get 10 points. My total cholesterol is 140, I get 0. My HDL is 70, I get to subtract 2 points. My blood pressure is 100, I get to subtract 2 points. I don't smoke, and, well, marijuana maybe, but not anymore. You know, actually, someone asked a good question about marijuana. I think this gentleman asked about marijuana. Actually, there's some evidence that it can cause a disease called Buerger's disease, seen in typically in young, heavy male smokers, Buerger's disease, thromboangiitis obliterans. So I have had a patient, actually not just a few months ago, that had his only risk factor for Buerger's disease was marijuana use. So you can calculate your total. I got a total of 6. So my vascular age is 42. Now, there's a problem with this, as you might imagine. It's a kind of a rough guide to what your vascular age might be. Because in fact, with this vascular age, I was out playing basketball and suddenly got a little lightheaded. I was about an hour and a half into a basketball game with the undergraduates. But I was feeling a little woozy. I checked my pulse and it was irregular. And actually it happened before, I have to admit it. I didn't tell my wife this, but it happened, well, maybe half a dozen times before when I was playing basketball with the undergraduates. But if I massaged my carotid, the arrhythmia would break. It's something us cardiologists do. But this time it didn't break, and I ended up going to the emergency room. And I was in atrial fibrillation, and I had to get cardioverted. I got cardioverted back into sinus rhythm. So my doctor, Randy Vagelow, said, okay, we got to make sure that, okay, you got a vascular age of 42. Good for you. But you just had this event. Let's make sure you don't have coronary artery disease. So you were asking earlier, a gentleman was asking earlier, how do you really tell, what diagnostic test can we do to tell our vascular age? So here's one, coronary calcification score. So you can do a CT scan now and look for coronary calcium. And as Dr. Dolman said, the calcium itself is not the problem. It does tend to find its way into plaque. Plaque gets calcified, but it's actually secondary to everything else that's going on in your blood vessel. Nevertheless, it's an indicator that you have atherosclerosis. Fortunately, this is not my CT scan. This is someone else's CT scan. I just wanted to show you what coronary calcium looked like. My coronary calcium score was 0, which was nice. I was happy about that. And actually, they did something more for me. This is even more specific information. You get a CT coronary angiogram, and you can get, here at Stanford, a nice look at the coronary arteries. And they all look clean. And you even get a nice picture of your heart. Look at that. 3D, that's my heart right there. Left anterior descending coronary artery looking very fine. And circumflex coronary artery coming along here looking fine. So at least I had my vessels, good, look good, no problem there. So my vascular age is about 42 maybe, but my wife says the problem is my emotional age, and she calculates a much lower emotional age. So I think that was the problem. So I'm playing with a slower group now, guys my own age.
Provide some context, John.
Yeah.
Your exercise regimen that might be related to your vascular age. How much do you run?
Well, I do exercise regularly, but now I'm doing it a little bit smarter. One thing you don't want to do is injure yourself. So at my age, you got to break it up a little bit. I try to do low impact stuff. I do run, but only once or twice a week now do I go on a long run. I cycle. I do the elliptical. I do some weightlifting, but lots of reps, low weights. It's not a really good idea to lift really heavy weights. It's better, for most of us. It's better to lift low weights and a lot of repetitions. Rowing is another thing. Rowing machine, do that. So low impact. The idea is a lot of frequency, a long period of time, low impact. I think, Ron, should I stop now? And I was going to go on to some of the research stuff that we're doing, but how are we doing for time?
Yeah, I think we've got probably another 10, 15 minutes if you want.
All right. Well, let me just completely address the question that this gentleman asked about diagnostic tests that can be done. Dr. Dahlman showed us earlier this ultrasound test. or mentioned the ultrasound test that allows us to see the carotid artery. And as you said, it's a very nice tool for finding plaque in the carotid artery. And one of the things that's being done right now is to look for the intimal thickening. Sometimes you'll see plaque like this, but sometimes you just see a little bit of thickening. When someone's just starting to develop risk for vascular disease, they'll get a little thickening of this intimal medial wall. Another thing you can do is functional tests. We discovered quite a few years ago now that the ability of the blood flow, the ability of a vessel to relax with blood flow, shown here, is entirely dependent upon that endothelial lining I was talking about earlier. So that thin film of tissue that invests your blood vessels, even though it's only one cell layer thick, it can markedly regulate vessel diameter. This happens to be an iliac artery, leg artery of a rabbit, but the same thing is seen in humans. If we have a pressure here of 60 millimeters of mercury but no flow, this is the dimension of the vessel, but we increase flow without changing the pressure. This is not a pressure effect. The vessel relaxes. This is entirely dependent upon the endothelium, because when we remove the endothelium, that ability of the vessel to relax is abolished. Now, we see the same abolition of flow-mediated vasodilation in people that have risk factors, even before they develop atherosclerosis. So if you're young and you're hypercholesterolemic, your radial artery, in response to changes in flow, will look like this. If you're healthy, your vessel will look like that with changes in blood flow. So we actually have tests that we can do in patients to assess flow-mediated vasodilation. We can use the ultrasound machine again. And in this case, we're looking at the radial artery. This is the brachial artery, sorry. And we can change the blood flow in the brachial artery by just blowing up a blood pressure cuff and to suprasystolic pressure and occluding blood flow for a moment, actually 5 minutes, and releasing the blood pressure cuff. There's a marked increase in blood flow and the vessel will dilate in a healthy individual. It will dilate less in someone that's got vascular aging. I want to turn toward some more futuristic things, approaches that we're thinking about at Stanford. And the idea is that to try to reverse vascular aging, which is, a lot of it is endothelial aging. These are normal endothelial cells lined up inside the vessel. This is what they look like, aligned with the flow of the blood vessel. Endothelial cells that have bend, branch, or bifurcation look like this. They're not aligned. They kind of look like cobblestone paving. And they're different. They're functionally different. Whereas these are making a lot of relaxing factors that relax the blood vessel. These are not. Whereas these are more like Teflon. They're not making adhesion molecules. These are making adhesion molecules. They're sticky. They're more like Velcro. And this is what your endothelial cells begin to look like as you get older as well. They become more like Velcro. So one of the things we're thinking about is how we can renew endothelial cells for people. Now, it turns out that we do have capacity. You've probably heard this story, that there are adult stem cells circulating in the blood for different tissues. And it turns out that there are adult stem cells circulating in the blood from the bone marrow that appear to enhance endothelial function. Some of them do so by releasing protective factors. Some of them actually incorporate into the blood vessel, into the injured areas of blood vessel. So those are adult stem cells. Now the problem is we get fewer of these as we get older. Their number is attenuated as we get older, and they're dysfunctional. They don't incorporate into the blood vessel as well, shown by Thomas Thum from Germany, done some nice work in this area. So adult stem cells are in the very people that we would like to be giving or enhancing adult stem cell mobilization. Those people have impaired ability to make adult stem cells. So you can derive stem cells from embryonic stem cells. I'm not going to talk about that because right now we're focusing on induced pluripotential stem cells. This is a very exciting new area introduced to the world by a fellow by the name of Yamanaka, who discovered that he, by overexpressing a few genes in a fibroblast, he could convert it into a stem cell. What he did was to pick a set of factors he thought might be important for pluripotentiality, for the embryonic stem cell state. And he overexpressed those factors in fibroblasts, and he found a set of 4 that actually were good enough to activate pluripotentiality. In other words, make a skin cell into a stem cell. These factors, these 4 factors, OCT4, SOX2, c-MYC, and KLF4, these are genes that encode what's called transcription factors. They're proteins that turn on a lot of other genes. And basically, they turn on the ability to be pluripotential. In other words, to become anything. Basically, what we can do now is we can take a skin fibroblast, a skin cell, from a patient. We do a little biopsy in the arm, and just a little tiny little piece of tissue, and we grow out the fibroblasts, skin cells, and then we overexpress these genes, these 4 genes in the fibroblasts. And over a period of several weeks, we start getting colonies of these induced pluripotential stem cells. And basically what these are what you were when you were first conceived, basically. They're basically pluripotential. They can become anything. They can become kidney, pancreas, brain. They could, theoretically become a tissue. So here's our IPS derived from a skin cell, induced pluripotential cell, and these could be used for tissue generation. They could be used for cell therapy. So we're working on this project, and because we're interested in vascular cells, that's what we're making. Renee Real-Pera, the Stem Cell Institute, has been helping us with this. This is Arwen Hunter over on the left that's been making the induced pluripotential stem cells in my laboratory. And these are what the colonies look like. They're very interesting. They tend to clump together. This is several hundred cells clumped together in a colony. And this is just different staining to show that these really are pluripotential. They're expressing factors that an embryonic stem cell would express. So basically what we've done is we've been able to create something that's like an embryonic stem cell from a skin cell. And then we've put these into immunodeficient mice, and they become different kinds of tissues: endoderm, mesoderm, ectoderm. And basically those are the 3 germ layers that ultimately form all of your tissues. But we're interested in endothelial cells, so we've figured out some methodology for taking these induced pluripotential stem cells all the way to endothelial cells. And they look like endothelial cells. They stain for the endothelial markers that we'd expect them to stain for, and they look like endothelial cells, and when we put them into matrigel, they form tubes. So these are things that endothelial cells do. They're behaving normally. So we're pretty excited about that. And then when we put them into, basically put them into a little matrigel, so it's like a little extracellular matrix, put them into an animal that's immunodeficient, so it won't immunologically react against the human cells, they form vessels. They form vessels in that gel that actually make connections with the mouse vasculature. You can actually see, if you look closely here, you can see mouse red blood cells here. You have to take my word for it. They're mouse red blood cells. They're there in here. And they're in continuity with the mouse. So we've created peripheral arterial disease in mice. We ligate the femoral artery in the mice, and they get, they recover from the surgery, but now they can't run quite as fast because they're not getting good blood flow to their limb. We can measure the blood flow with laser Doppler spectroscopy. And we've been injecting our cells, our human cells, into these legs to see if we could improve blood flow. And the good news is we can. This is a measure of blood flow here. It's called laser Doppler spectroscopy. These are animals treated with just saline. This is buffered saline solution. They do get a little bit better over time, but not much. If we just put in the human skin cells that we harvested initially, we don't get any benefit. But if we put in inject right into the muscle of the animals, right into the leg, the endothelial cells, we do get some improvement. Okay, so it's not a lot, but it's kind of like the Wright brothers taking off. We got some proof of concept. So that's the idea. But now I think, to really get to improve these patients with peripheral arterial disease, we're going to have to get pulsatile blood flow down there. So I think we're really going to have to make grafts with these cells. We're going to have a conduit, a pipe, like a vessel. So I have a bioengineer in the lab, trained at MIT, and we're putting cells into matrix, different matrix, tubes and other patches and threads. And these are endothelial cells that are growing very nicely on some of our graft material, and we've been putting those into our animals. Ultimately, what we'd like to do is create new blood vessels. So we'd like to, for a person that has peripheral arterial disease, very severe peripheral arterial disease, take extracellular matrix conduit, some collagen tube, and what we want to do is implant their own iPSC-derived endothelial cells, vascular cells, into that tube, and ultimately get a vessel that we can implant in that patient that their body won't reject. That vessel feels like self to the body. So that's one of our long-term plans. We actually, I signed a contract today with a company that makes harvest veins from cadavers. And the problem with those veins is that your body will react to them. It's from another individual. So the company removes the cells and then gives the vascular surgeons like Ron Dahlman just the tube, basically the collagen tube that's left after they remove the cells. It doesn't work very well. So what we're going to do is we're going to put the cells back in, the patient's own cells, back into that tube and see if we can't make something useful. So that's it. These are the guys that are working with me doing the basic research. But so I'll stop there and I'll take questions about the research, or we can go back to the vascular aging issue and what you can do now to prevent vascular aging. And maybe I'll ask Ron Dahlman to come back up with me and take some questions too. Thanks for your attention.
How much could a good HDL help having the LDL, or how does that really differ?
Well, I don't have a new number for you,
Yeah.
but it's better to have a high HDL cholesterol.
What does it do?
What does it do? It's thought that HDL cholesterol removes cholesterol from where it shouldn't be and carries it back to the liver. So the idea is countertransport. So LDL cholesterol delivers cholesterol, and it's evolutionarily it's a good thing because you need to get cholesterol to wounds. You need cholesterol for cell membranes to maintain and to heal. But you also need a way of getting cholesterol back to the liver, and HDL does that. Yes?
With regard to these stem cells, you told us what your plan is, but you also mentioned earlier that these cells can, in young people at least, can repair endothelial imperfections. Could that be a therapy? Just injecting these peripheral.
Right. Actually, you're absolutely right. We're thinking along those lines too, just injecting the cells into the vein and let them circulate. The concern is, though, we don't know for certain if these cells are perfectly normal. And before we start letting them circulate all around a person, I think we feel better if we confine them a little bit first and see how they do there. Any questions for Dr. Dahlman? Let's get a question for the vascular surgeon.
That's okay.
There's a question right here, Ron.
So I think you mentioned something about aneurysm screening, and if you're 65, you can get one for free or something like that.
If you're a man, you smoked over 100 cigarettes in your lifetime, and you're initiating your Medicare benefits, part of your Welcome to Medicare physical exam, you're eligible for that.
So you just talk to your health
Primary care.
provider and tell them if you want one.
Yep, primary care.
Okay.
Of course, they can also do a physical exam, and if they feel a prominent aortic pulse, then it's no longer a screening exam. You're following up on physical exam findings. You can get one that way too, if you need it.
Yes,
What about cancer cells? Like if you're putting cells experimentally in bodies, can the body genetically change these cells into cancer cells? Or even if you have cancer already?
That's a good question. So the question is, if we put these cells into patients, what if the body causes them to turn into cancer stem cells? Well, they may actually have that they may have that potential. That's what we're concerned about. That's one of our concerns, is that these could become cancer stem cells. So, there's a lot more work that needs to be done. I think it's better to confine the cells into a conduit first for that reason. And I think let's get some questions way at the back here. Yes.
So when you go to, let's say you perfect this, and you're taking the skin cell, and a person's skin cell, and you're growing their own new vein, or what's the turnaround time that you conceive of?
Oh, what's the turnaround time? Well, it's going to take some time. There's actually a company that's, no, months. There's a company actually that's doing this right now called Cytograft, and they actually have a turnaround time of about 6 months, but they're not using these induced pluripotential stem cells. Our cells have great replicative capacity. They're using endothelial cells derived right from the body, and so those cells don't proliferate very well. So I think we'll be able to do better than that. But that's an important question. It's a business model problem. Yeah. Way in the back, yeah.
You showed a bunch of tests for evaluating the health of your arteries.
Mm-hmm.
Do you see a time when people, when they reach 50, 55, or those levels that you kind of mentioned on the scoring there, where it'll sort of be like a colonoscopy, and everybody at that age will just go in and get a set of tests to see what their score is?
Ron, do you want to answer that?
Well, that's what molecular, we have another colleague who's not here with us tonight in cardiology who's interested in molecular imaging, and actually the chair of the radiology department is very interested in that too. And the idea would be to find specific proteins or cell types which are suggestive of vascular events. For example, if you have an aortic aneurysm, which has been identified by ultrasound screening, but isn't large enough to repair yet, what's the best way to potentially monitor that over time? Or, we're working on medications that might help prevent the enlargement of those aneurysms. So how do you know the medication's working, or do you need to change the medication? Guided therapy and guided diagnostics, cell-based diagnostics are a great interest at this point, and have a lot of people working on that at Stanford. But you have to keep in mind cost effectiveness too, and for a lot of people, like John's simple calculator there, it's pretty low tech, but it gives you some idea whether you really have to be worried about something or not based on known risk factors. So it remains to be seen whether those expensive and exotic cell-based tests are going to be better than the epidemiologic data of the known risk factors in relationship to that.
I have also an answer to that too. In addition to what Ron said, there is a simple vascular test that everyone over the age of 65 should get. It's an ankle brachial index. Ron mentioned it already. It's basically measuring the pressure at the ankle as well as the pressure in the arms, and calculating the index, just the ankle pressure over the brachial pressure. And that's actually a very important test because it adds independent predictive information whether or not you're at risk for cardiovascular disease. It's recommended now by the American Heart Association that everyone over the age of 65 get it. Every smoker or diabetic over the age of 50 should also get that simple test. The cardiologist is going to kind of do the calculations based on that exercise that we went through, and think about other tests that you might need too, like an electrocardiogram. Might put you on a treadmill and see how you do with exercise before he or she recommends an exercise program for you. That's what I would do. Certainly for anyone coming to me at the age of 50 for evaluation, something I would think about before I ask them to start an exercise program is put them on a treadmill exercise test, make sure they don't have an arrhythmia, make sure they don't have myocardial ischemia, poor blood flow to their heart based on their performance on the treadmill. Yeah, any other questions from the back? Yeah, Ron.
In the middle there, that guy had a question.
Dan?
Yeah, I'll ask one that was, like, maybe both of your opinions on this. There was a panel at the American Heart Association a couple of years ago, and the debate was, should everybody be put on a statin? Or I think the way they phrased it is, should we just add statins to the drinking water? And I'd like your opinion, and that was a couple years ago, so there's a couple more years worth of data on the effects of statins. And there are so many of us who are on or not on statins at this point. I'd like both of your opinions on that one.
Okay, well, statins. Obviously, there's a lot of epidemiologic data related to cardiovascular events based on lipid levels, and statins are effective in addressing those. Statins, however, also have what they call pleiotropic effects that apparently are not related to lipid levels. Statins they're not a panacea. For example, if we look at the aortic aneurysm data, if you do a meta-analysis of all trials of statins for patients with aortic aneurysms, you find that there appears to be no effect on the rate of enlargement of aortic aneurysms of patients on statins. And the higher quality trial it is, the more patients who are enrolled, the more carefully the study is monitored, the less effect there appears to be. But the actual patients taking the statins live longer than the patients not taking the statins, even though their aneurysms grow at the same rate. So I think that there's other, patients who have aneurysms tend to have other cardiovascular risk factors. So there are a lot of people who can't take statins. They get, side effects, muscle cramps, rhabdomyolysis. There's other issues related to that, but I think that, yes, I think the majority of people who have significant cardiovascular risk profile beyond a certain age, 40, 45, probably are well advised to take a statin. There is some concern about diabetes, though, I guess, as a complication of statin therapy or other long-term concerns with it. Maybe John can give us more information on that. John?
And that's a great question, Dan, because the statins are relatively safe in terms of the drugs. The drugs we use, they have very low side effect profile, although some patients can't tolerate it. They get an inflammation of their muscles called myositis. Should we put it in the drinking water? I don't think so. It would be expensive. But there's another thing that you could consider doing, and that is use Chinese red rice yeast, if you can get it.
Chinese. Who in the audience knew about Chinese red rice yeast? There you go.
This is a good. This is a pretty
people,
smart
right?
group. Yeah. Well, so you know that a Japanese scientist by the name of Endo discovered something in Chinese red rice yeast. It was basically mevinolin, which became Mevacor, the first statin. And so now it's a $12 billion industry derived from Chinese herbal medicine. Chinese red rice yeast has been used in China for millennium, and it's in fact in the Chinese textbooks, the old Chinese textbooks, it's used for circulation, quote circulation. It's also used as a food flavoring, and it's very popular food flavoring, and it's widely used in China, and so it's probably something that we should be putting in the water.
Diabetes is a long-term risk of statin therapy. John, do you know much about that?
There has been some talk about that, about statins predisposing to diabetes. But then again, it's what you said. The people on statins seem to be living longer,
Well,
despite
it's
their risk factors.
Fascinating. Pfizer made, what was I reading the other day, $120 billion off of Lipitor, something like that. That's staggering concept. Yeah.
Could you talk about secondhand smoke with aneurysms?
Don't know much about secondhand smoke and aneurysms. As I said, there's exquisitely detailed connection between cigarette smoking and aortic aneurysms. Don't know exactly what the additional risk is of secondhand smoke. This one guy's had his hand up for just a second.
Actually, I can answer.
Okay,
I was going to
yeah,
answer.
go ahead.
I can't speak for aneurysms specifically, but for cardiovascular disease, as you know, many cities around the country actually spurred on by the work of a brilliant physiologist up at UCSF who has been the main individual who has been the proponent of smoking bans for secondhand smoking. Within 2 years after New York City passed a smoking ban on smoking in restaurants and bars, there was a substantial, noticeable, and statistically significant difference in deaths and hospital admissions due to cardiovascular disease. So there are real quantifiable differences within a fairly short period of time related to secondhand smoke.
I have something to add to that too. So secondhand smoke also has been very good evidence that it increases respiratory risk in children for asthma and that kind of thing. Okay, this is a smart group. Who's heard of third-hand smoke? Anyone? Third-hand smoke. Yeah, this is real. I first heard about it, I said, wow, what a great grant concept for funding from Tobacco-Related Disease Research Program. But yeah, third-hand smoke is real.
Which you're all paying for, by the way. Proposition 90, whatever it was.
Yeah, right.
Proposition 98, I think.
But it's actually a very cool idea. So you've known this. You've walked into a hotel room where someone's been smoking, right? And it actually smells worse than secondhand smoke. It smells stale, it smells nasty. That's third-hand smoke. And what's going on there is that the secondhand smoke is accumulating in the rugs and the carpet and the drapes, and it's those act as catalytic surfaces. And the bad stuff in secondhand smoke gets badder. It gets more oxidized. And then it elutes off the drapes and the rugs and back into the air, and that's what you're breathing in after someone was smoking. Third-hand smoke.
Let's get this question in the middle here before time runs out. Yes?
I was curious, what are the causes of LDL oxidation?
What are the causes of LDL oxidation? There's, well, multiple causes. Vascular cell, the vasculature exposed to high cholesterol will start to generate superoxide anions. And that's actually much of the oxidized LDL cholesterol in the blood vessel is actually due to the action of the vascular cells on the LDL cholesterol. Inflammatory cells make free radicals that oxidize the LDL cholesterol. Time for more questions, Dan, or should we call it quits?
Yeah.
Oh, yeah, right here.
Chinese red rice meat.
Yes.
Can you get that around here?
Trader Joe's, right?
Yeah. Be careful. Be careful, because these nutraceuticals, as I told you, they're heterogeneous. I was actually played in this world for a little while. And, but one thing I found, I had a patient come in one day telling me, I got some Chinese red rice yeast, and I was surprised, because the FDA embargoed this 10 years ago. There was a company called, what was it, Colonex? The company that was making Chinese red rice yeast and selling it to give you healthy levels of cholesterol. Well, I guess the pharmaceutical companies found out about this. They didn't like it, and the FDA ended up embargoing all the Chinese red rice yeast. So I was wondering how this patient got Chinese red rice yeast. So, you know, he showed it to me, and it was some sort of, it was red. And then I looked at the very fine print on this box, and it contained high levels of niacin, nicotinic acid, which is good. I mean, it can lower your cholesterol, but that was what was lowering his cholesterol. It was the nicotinic acid. And there was some red stuff in there. I don't know what it was, but it was nicotinic acid, I think, that was lowering his cholesterol.
Yeah.
Yes?
One question for the surgeon and then one for both of you. So how do you actually fix an aortic aneurysm or other
So we-
and then
yeah.
real quick, should we all be on aspirin?
I have video. I don't have time to show it, unfortunately, but actually I never really got around to that, but that's an area of dramatic technological improvements. Most initial work actually done at Stanford, where a covered stent can be placed through femoral access and line the aorta with fixation at the healthy part of the aorta above and below where the aneurysm is, and just divert blood flow through the aneurysm. So just in the last 10 years, we've about come full circle. 80% of aortic aneurysms are repaired that way now nationally, rather than a large incision and move everything out of the way and sew a new graft in place. So that's a huge improvement in the treatment, and that kind of goes, that goes hand in hand with the screening is there, the treatments are improved, the options are a lot better. Aspirin. Aspirin's a great vascular vitamin. It's good for a lot of things. Like statins, it's not exactly a free lunch. It can upset your stomach, and some people are allergic to it. But reduces your chance of second heart attack. It reduces a number of vascular events under different circumstances. And essentially all the patients that we see in clinic that have vascular disease are on aspirin. So that's an important addition as well. John, you want to comment to that? Actually, salicylic acid is also beneficial as an herbal. It's an interesting story about how aspirin became aspirin. Bayer added this acetyl moiety to salicylic acid. The salicylic acid, which gets from tree roots or something, willow, actually is quite advantageous to vascular disease as well. But there's no company promoting that. But there's a research group at Penn or whatever that's done quite a bit of work with salicylic acid. John.
I think if your risks are very low for vascular disease, I would say don't take aspirin. There's been some more recent evidence that people that are low risk are not benefited by aspirin, and then you just have the baggage, which is the gastritis that can occur. So if your risks are very low, but if you have moderate risks, and certainly if you have high risk for vascular disease, then you should be on aspirin. And I'm sorry about my answer about the Chinese red rice yeast. It wasn't very good, but I mean, I just don't know a good source, frankly. And
so, can I ask a question? Why would you recommend something if you don't know how?
Well, I do recommend surgery from time to time too.
Can I just say, very rarely in my experience.
Right. When we have one last question and then I think.
So you mentioned something about ankle.
Ankle brachial index. Ankle brachial index. So the ankle and the arm, it's an index. Just the pressure, it's blood pressure.
Blood pressure,
So
2 areas.
is that my provider, AMR?
Yeah, they can do it.
Yeah,
Well,
well,
they take my blood pressure when I come out.
we'll be happy to do it for you. We'll be happy to measure an ABI for you, an ankle brachial index. But
Vascular.stanford.edu.
there you go. Actually, you know, unfortunately, most people are not doing it, and most primary practitioners are not doing it. They should be, but they're busy and they don't get around to it.
For more, please visit us at stanford.edu.